Bismillah ar-Rahman ar-Rahim. Now I'm starting our lecture today, how to read CT scan nose and paranasal sinuses. We know all we know, no CT, no FESS. The best example for this, the CT for my patient for about 4 years came to me with facial pain and nasal obstruction. This CT shows complete abscess of right maxillary sinus. This emphasizes the need for CT scan before any nasal surgery, not only the FESS. If anyone will do a FESS for this patient, there's a complication, at least orbital injury, even traditional enteral wash, because there is no maxillary sinus. So very important to do CT for every patient if you want to do a FESS for this patient. I used to use this fantastic software, Daikon Viewer, to see the CT scan for every patient in 3 modes: axial, coronal, and sagittal. And use 1 million, this 1 million cut, not the 5 cut, 1 million cut for best reconstruction in the three models, axial, coronal, and sagittal. We start from the first cut in coronal gland. We will start with the coronal, then axial, then sagittal. The first cut shows this the change laser mode. This is the nasal septum, cartilaginous, partly thickening, and this is the nasal bone and the frontal bone. The second cut shows the frontal sinus appear now. This is the nasion, the nasofrontal beak, and this is the nasal bone. I started the ascending process of maxilla to appear, and the nasal septum, the bony part, start to appear, and this is the swell body and the part of the rest of the septum. Now this premaxilla start to appear and ascending growth of the maxilla. Right and left ascending growth of the maxilla merge together in the center to form the nasofrontal beak. And this is the frontal sinus, and this is the cell. The first reading of CT scan, avoid to mention any pathology, just to see the normal pathology anatomy first. This is the upper and the lower eyelid. This is the swell body, premaxilla. And this for another patient to see if there is this the lamina paparicia. This is the septum. This is the nasofrontal beak. If you see this picture and there is continuity between the lamina paparicia and the nasal septum, so you are in the frontal sinus, not the frontal recess. This is the frontal sinus because there is continuity between the lamina paparicia and the nasal septum, and there is bone in between. More posterior to see the frontal sinus. See the right frontal sinus, there is a continuity between the lamina paparicia and the bone is the nasal septum. So the right, this is the frontal sinus. And this is, there is no continuity between the lamina paparicia and the nasal septum. So this is the frontal recess. The maxillary cells start to appear, and this is the first ethmoidal cell appear, and this is agar nasal cell. This is the nasal septum, and this is incisive canal and foramen. More posterior, this is the inferior turbinate, maxillary sinus, a nasal septum, middle turbinate, paradoxical, bends medially, not laterally. This is the agar nasal cell, and the nasolacrimal duct start to appear here. You see the relation between the nasolacrimal sac and agar nasal cell. the posterior surface of the nasolacrimal sac in close contact with the anterior surface of the agar nasal cell. Sometimes we open the agar nasal cell always when we do DCR. And this is the frontal recess, and the right side it's appear very clear the nasolacrimal duct. More posterior maxillary sinus start to be large, and this is the agar nasal cell, which is very large, and start to appear the uncinate process. This is the nasal septum and the frontal sinus. Don't confuse between a large agar nasal cell and ethmoidal bulla. This is not ethmoidal bulla. This is agar nasal cell. Ethmoidal bulla more posterior. As you know, the attachment of the upper part of the uncinate process either lateral to the lamina papyracea or superior to the skull base or medially to the middle turbinate. This more posterior cut shows the septum thickened, inferior turbinate, middle turbinate paradoxical, and superior attachment, a globe to be large, and the frontal sinus. This is the frontal recess medially. This whole classification of frontal recess and the frontal sinus cell. This old classification was founded by Kohn. The agar nasal cell, this more anterior, this anterior group, the agar nasal cell, supraorbital ethmoidal cell, supraorbital ethmoidal cell, which is the cell pneumatized around anterior posterior or around the anterior ethmoidal artery, sometimes for the posterior part of the frontal sinus. Of frontal cells of 4 types. Type 1 single frontal cell above agar nasal cell is constitute about 37%. Type 2 tier of cell, 2 or 3 cell above in the frontal above the agar nasal cell is around 19%. Type 3 cell single massive cell pneumatizing separated in the frontal sinus about 7%. Type 4 cell isolated cell in the frontal sinus, which is rare. This is the anterior group. The posterior group, frontal bulla cell, which consists of posterior parts, are pneumatized in the posterior surface of the frontal recess and sinus. Suprabullar cell not reaching the frontal sinus, interfrontal sinus septal cell. This is medially and push the frontal recess laterally. This is all the classification. B.J. Wormald constitute type 4 cell is not significant clinically. So delete the cell, and there is a modified Kohn cell founded by Wormald. He stated that type 3 cell is a single massive cell pneumatized separated in the frontal sinus, and it constitutes the dimension of this cell less than 50% of the height of that frontal sinus, inside the frontal sinus. And type 4 cell more than 50% of the length of the frontal sinus. Some of picture of CT sinus of this lecture from this book, Endoscopic Sinusal Dissection Guide by Roy Cassiano and Islam Herzallah. This demonstrates the whole classification. This is the old classification system. This is the red one. This is the agar nasal cell. This is the type 1 cell, T1 cell. This is in the right, in the blue color, T2 cell. And the green one is the T3 cell, and this one T4 cell. This now, no one use this classification now. Now the new classification system, International Frontal Sinus Anatomy Classification (IFAC) system. There is anterior, posterior, and medial group of cell. The anterior group, agar nasal cell, a frontal ethmoidal cell, Frontal ethmoidal cell, supra-agar cell is constitute T1 and T2 in the old classification. And supra-agar frontal cell constitute T3 and T4 in the old system. Posterior group, bulla ethmoidalis, suprabullar cell not reaching the frontal sinus. A frontal bulla or suprabullar frontal cell reaching the frontal sinus. And the posterior wall of this cell constitutes the skull base. Supraorbital ethmoidal cell, this is the cell pneumatized around the anterior ethmoidal artery, anterior or posterior or around it, and constitute the posterior part of frontal sinus. And the medial group intersinus or frontal septal cell. The anterior group push the frontal recess posteriorly or medially or posterior medially, and the posterior group push the frontal recess anteriorly or anteromedial, and the medial group push the frontal recess laterally. This sagittal section show this is the frontal beak, nasofrontal beak, this is the frontal recess, and here's the frontal bullar cell once reach. Excuse me. This is the suprabullar cell, and this is the suprabullar frontal cell, and this is the agar nasal cell. Okay. This section shows this is the agar nasal cell, and this T1 cell, only one cell above the agar nasal cell. This T2 cell, this is the agar nasal cell, and these two cells above the agar, so this is T2 cell. This T3 cell, this is the agar nasal cell, and this cell pneumatized separated into the frontal sinus. This is the T4 cell inside, completely inside the frontal sinus, and this is all the classification. More posterior, we see the incidental process hug the agar nasal cell and constitute the medial wall of this agar nasal cell. More posterior, bulla ethmoidal start to appear. This bulla, and this is the middle turbinate attachment cephalate to the skull base. This is the bulla ethmoidalis. This section is very important. Here we see the nipple between the nipple of Kennedy between superior oblique and medial rectus muscle, from which the anterior ethmoidal artery emerges from its origin from its origin to the septum. If there is superior notilization above this anterior ethmoidal artery, this is the notilization, this is the black cell, so the artery lie in a mesentery, not in the skull base. So this artery will be injured easily in any surgery in the frontal recess. So be careful when you see this picture if there is pneumatization above the anterior ethmoidal artery. This show the olfactory fossa and recess. This is the olfactory recess, and this is the olfactory fossa, and this is the horizontal lamella and lateral lamella, and this the fovea ethmoidalis. See the difference in the thickness between the fovea ethmoidalis, which is very thick and hard. Lateral lamella is very thin, and this the horizontal lamella or olfactory fossa is very thin. So there is a Kuros classification now. Kuros 1 from 1 to 3, of 2 from 4 to 7, and from 8 to 16 or 17. More posterior, we see there is an pneumatization of lamella of middle turbinate in the right and left, the bulla ethmoidalis, and this is the infraorbital nerve. This is the muscle, medial, lateral, superior, and inferior rectus muscle. Lamina papyracea classified by Herzella into 3 types. Type 1 of lamina papyracea when it lies at the same level of osteometal complex. Type 2, when the lamina papyracea lies medial to the osteometal complex, and type 3, lateral to the osteometal complex. Type 2 is more dangerous during ancillary, especially the anterior approach to ancillate. You will insult the orbit if you don't remember this classification or you don't read the CT carefully. We go more posterior, see this picture, this maxillary sinus, inferior turbinate, this middle turbinate curve laterally to the lamina, and this is the basal lamella. So this is the anterior ethmoid, this is the posterior ethmoid. Still, the anterior ethmoidal artery lies in the mesentery. It's very clear. And this CT shows the skull base, asymmetrical skull base. When you see asymmetrical skull base, you put in mind there is either it's a normal. If you see continuity of the bone of the skull base, this is a normal. Or if there is no continuity, you put it in cephalocele or any pathology in this area. If you did a FESS or any surgery in the left side, put in your mind this is high level down the right side. This shows very clear the Kennedy nubble and the anterior ethmoidal artery and the pneumatization above this, and this is run in a mesentery and that is in the skull base. One of my patients came to me with this picture of ethmoiditis. The left normal side see the anterior ethmoidal artery run in a mesentery. So I expect the right ethmoidal artery run in the mesentery also, but I can't see it. So I expected to when I did a surgery in the frontal recess and I insult this artery. This video shows injury to the anterior ethmoidal artery. Give me a break, please. This patient complained from skull base defect. This is very large defect. This is the nasal septum. This is the left side. This is the nasal septum. This is the lamina papyracea. This is the frontal sinus and recess. This is the sphenoid. And this is the skull base defect. This is the side of craniform blades. And I resected all the middle turbinate. I expect the course of anterior ethmoidal artery from the lamina to in this part between the frontal sinus and this defect from the lamina papyracea to the septum. Sorry for that. See how fast and how easy the artery will damage during surgery. This is the artery. This is the anterior ethmoidal artery. And this is the shaver. I have to examine the orbit. Can deal with easily by cautery. And now bleeding stopped. Okay. More posterior. The posterior ethmoid is different from the anterior. The skull base become more horizontal and thicker. The posterior ethmoid cells larger, triangular than the anterior cell. Inferior orbital fissure and the orbital apex more posterior. More posterior, this is the orbital apex, infraorbital fissure, supraorbital fissure, and this is important structure here. This is the sphenopalatine foramen and the sphenopalatine artery here. This is the pterygopalatine fossa. This is the tail of the middle turbinate, and this is the sphenopalatine foramen and pterygopalatine fossa, are separated from the infratemporal fossa. From this infratemporal fossa by pterygomaxillary fissure. So this is the tail of middle turbinate, sphenopalatine foramen, emerges from the sphenopalatine artery, pterygopalatine fossa, infraorbital fissure, infratemporal fossa, pterygomaxillary fissure in between. This is show the pterygopalatine fossa as a six-wall cavity, and this more posterior pterygoid plate, medial and lateral pterygoid plate, pterygoid body, and this is the sphenoid sinus. The sphenoid sinus, there is two important structure here. This is the foramen rotundum superiorly and inferiorly the Vidian canal, and this is any sphenoid sinus with horizontal septum. Expect there is this onodicial, expect there's a dehiscent in the optic nerve. This diagram shows pterygopalatine fossa. I am sitting here in the right maxillary sinus. See this picture. This is the sphenoid sinus, this posterior ethmoid, and this foramen rotundum, V2, this part the maxillary artery. And this is the pterygomaxillary fissure, which separates the pterygopalatine fossa from the infratemporal fossa, and this is the greater palatine canal. This is the orbital apex. This shows the sphenoid sinus, a sphenoethmoidal cell, and this is the optic nerve in it. This lateral recess, which we will discuss later on, and this pneumatization into lesser sphenoid wing in the anterior glenoid process. More posterior view show the sphenoid sinus as one cavity and foramen ovary V3. Axial view from inferior to above show posterior. This is the nasopharynx. This is fossa of frozen molar. If there is any, we can read this in patient with nasopharyngeal carcinoma emerge from this side. This fossa of frozen molar. This is the osteocheic tube. This is the pterygoid plate, medial and lateral. This is the medial and lateral pterygoid muscle. And this is the maxillary sinus, inferior turbinate, septum, and septal body. More superior view show this is the Vidian canal, pterygopalatine fossa, infratemporal fossa, pterygomaxillary fissure. And the septum bifid posterior into two parts. And this is the clivus. More superior, we see the pterygopalatine fossa, bilateral very clear. This is the nasolacrimal duct. More superior, we'll see important structure here. This carotid artery, bilateral. It's important to see if carotid dehiscent, because any surgery in the sphenoid sinus may insult the carotid artery, and resulting is very serious complication. This is the superior orbital fissure. This showing the Vidian canal. This is the Vidian canal, and this the pterygopalatine fossa. This is the infratemporal fossa. More superior showing this foramen rotundum, middle cranial fossa, and the V2 transits from the middle cranial fossa through the foramen rotundum to pterygopalatine fossa to the orbit. This section shows the sphenoid sinus with both carotid artery and the septa of the sphenoid sinus attached to the carotid. So you have to deal with this carefully, because if you pull this septum by any instruments, you may make injury to the carotid artery and severe bleeding. This one of my patient with schwannoma reaching the sphenoid sinus. See how the carotid is near to my instrument here. More severe cut showing the labyrinth anterior and posterior ethmoid, and you can see the nipple of Kennedy here, anterior ethmoidal artery. More severe cuts showing the ethmoid anterior and posterior, and the sphenoid more posterior. More severe cuts showing the cribriform plate, the lesion. In this cut, we can see the frontal sinus and the frontal recess in the same plane. More severe, can we see the frontal recess? Can examine the anterior and posterior table. There is a variation, retromaxillary pneumatization of the posterior ethmoidal air cell, founded by Islam Herzallah, is a well-known Egyptian scientist. He called Herzallah cell. Herzallah cell or retromaxillary pneumatization of the posterior ethmoidal cell, which is the cell founded more posterior behind the maxillary sinus and anterior to pterygopalatine fossa. So any tumor or any disease in this area, you have to clear it and put in your mind the pterygopalatine fossa is more posterior, so there is a retromaxillary cell between the maxillary sinus and pterygopalatine fossa. This is sagittal view showing the pterygopalatine fossa retromaxillary cell behind the maxillary sinus. It's of three types: type 1, 2 mm, type 2, 3 to 6 mm, and type 3, 7 mm. In sagittal view of the CT scan, we can appreciate the three fossa, anterior, middle, and posterior fossa of the brain, of the cranium, and we can reach the anterior, middle, and the posterior cranial fossa through the nose, through transfrontal or transcribriform, transplanum, transcellular, transclavus, or transodontoid. This sagittal view showing this is the frontal beak, nasofrontal beak. This is the cribriform plate, and this is the vomer, the sphenoid sinus, and this is the cella. This more lateral view showing very clear the beak, there is a frontal beak, and the crista galli here, the sphenoid sinus. In this view, we can see the rule of 6 of the anterior posterior ethmoidal artery, optic, and lacrimal crest. This is the nasolacrimal duct, and this is the anterior lacrimal crest. 24 mm from this crest to anterior ethmoidal artery, and 12 mm from anterior to posterior ethmoidal artery, and 6 mm from posterior ethmoidal artery to optic nerve. This view showing this is the sphenoid sinus, and this is the optic nerve. We can find the posterior ethmoidal artery 6 mm anterior to it, and 12 mm anterior ethmoidal artery anterior to it. This sagittal view showing the pterygopalatine fossa with the greater palatine canal posterior to the maxillary sinus. This is the hard palate. This view showing the Vidian canal to the pterygopalatine fossa, and this is the greater palatine canal. Also, sphenoid sinus maxillary in between pterygopalatine fossa and greater palatine canal. This is the Vidian canal and pterygopalatine fossa. We use the greater palatine canal to block the sphenopalatine artery through this is needle in the greater palatine canal. we use this is in FESS and certain dental surgery. We found this in the upper molar, midway between upper molar tooth and the mid-palatal line. This is the cadaver because there is air in the brain. Very important to know anatomy in detail about the sphenoid sinus. The importance of the sphenoid sinus because of the very important and risky neurovascular bundle in the lateral wall. So there is optic nerve, carotid, and the cranial nerves. And there's 5 types of sphenoid sinus. This is the conchal type with the least type of 3 to 5%. There's no air at all in the sphenoid sinus, and the posterior wall of the sphenoid sinus far anterior to the sella turcica. Type 2 precellular sphenoid sinus, the posterior wall of the frontal sinus is lie at the anterior wall of the sella turcica. Cellular type, the posterior wall of the frontal sinus lies at the posterior wall of the sella turcica. Both cellular without air behind the cella, the pneumatization behind the sella turcica without air behind the cella. The type 5, both cellular with air behind the cella. This is the both cellular pneumatization with air behind the cella. Lateral and inferior pneumatization. There's certain pneumatization of the frontal sinus. We have to know the pneumatization of the front of the sphenoid sinus before doing surgery in this important and risky sinus. There is inferior pneumatization between the median and rotundum foramen through the pterygoid blade. In this type B, there is a lateral pneumatization in the greater wing of the sphenoid bone between the median and foramen rotundum. In type C, there is a lateral through the greater wing of the sphenoid and inferior through the pterygoid blade. And there is also superior pneumatization through the lesser wing. Anterior pneumatization resembling the Herzilla cell or posterior ethmoidal pneumatization, but from the sphenoid, not from the ethmoid, anteriorly to line posterior to the maxillary sinus. Also, there is a classification of the sphenoid sinus according to the foramen rotundum and the Vidian canal. Type 1, where the foramen rotundum is placed completely within the sinus cavity. Type 2A, when a part of foramen rotundum is in the sinus cavity or partially protruding into sphenoid sinus. Type 2B, when frontal foramen rotundum is tangent to the sinus wall, يعني بشكل مماسي. Type 3, when foramen rotundum is placed completely within sphenoid sinus. Also, there is the same classification of Vidian canal, same to the foramen rotundum. Also, sometimes I need to do 3D reconstruction of the CT scan of the patient to see erosion of the bone of the sinus of the tumor of infection. Like this patient came to me for 3 years with allergic fungal rhinosinusitis of the frontal sinus with a proptosis. See how the big defect of the supraorbital blade for this patient. I did for this patient a draft-free surgery with orbital displacement. Now it's very well. This patient came to me for 3.5 years with left maxillary sinus adenocystic carcinoma. I did for him medial maxillectomy, Dunker approach, see the defect of a breast surgery. Now, before a few months, come to me with right maxillary sinus tumor, recurrence of the same tumor, but on the right side. See how the defect is in the anterior maxillary face. So I appreciate from this picture, this is not candidate for endoscopic surgery, and I did for him external approach for Ferguson surgery. My appreciation to Professor Roy Cassiano, who changed my perspective to FESS and CT scan. And thank you. دكتور ماجد إذا تسمعني regarding patient with trauma to the anterior modal artery just categorized by bipolar or unipolar. No problem with that. I showed that in the video. Regarding fungal sinusitis, yes, it's a curable disease. Now this patient now for 3.5 years without recurrence. دكتور فايل أمبكي how localized retromaxillary retromaxillary rheumatization is important if there is angiofibroma. We have to clear this important cell to prevent recurrence or there is any tumor or infection. And sorry for Dr. Fal, the localization of retromaxillary cell by axial CT is better. Dr. Osama, I'm not asking for film from the CT. I do CT CD and I prepare it in my laptop. I prepared an axial, sagittal, and coronal by my own software in my laptop. دكتور فراس مشتاقين إن شاء الله. I depend on the radiology report or the film, only the CD, and I have in my laptop 2 or 3 software, and I prepare my CD by myself, the CT slices, I mean. Dr. Osama Fahmi. I use Daikon Viewer. It's free in the Google. Daikon Viewer. حتى تحديثه مجاني. You're welcome, Dr. Osama. The importance of chronic classification. You have to know if this is type T1 or T2, T3 cell during uncapping the egg, as Sternberger principle of opening the frontal recess. You have to know you open this, you are in the frontal sinus proper, or you are still in the agarnesia, or still in the type 2-1 cell. You have to know how much type of cell in front of you. Above the agarnesia cell. So it's very important to know how many the cells there, 1, 2, 3 cells. Because if there's a 3 cell, type 3 cell, there's 3 cell, you open the one and you don't have navigation system, you don't have, this is the large T2 cell, or you still in the frontal sinus. Okay? باش طالب دكتور ماجد؟ internal insult to internal carotid artery. If there is insult to internal carotid artery, it's very difficult to treat. First, I have to control it by putting gel foam or surgery and preparing a muscle patch from the thigh and put it muscle patch and terminate the surgery and send the patient for interventional radiology to do what they do. But it's mainly fatal, and some patients I know outside, they died at the operation room. So you have to read the CT carefully before you're doing a surgery in the sphenoid sinus, because the injury to the anterior carotid is fatal. You're welcome, Dr. Khalid. There is no grading system, Dr. Sahar, no grading system for onody cell. The presence of the onody cell is enough to know there's maybe a dehiscence in the optic nerve. The grading system only for pneumatization, VDN, and foramen rotundum. Dr. Majid, how differentiate from cavernous sinus? The cavernous sinus is the venous bleeding. It's not so severe. It's not a projectile which can't controlled by surgery seal, gel form, or flow seal. But no cautery in the sphenoid sinus and in the cavernous sinus. We can't buy Brodger from gel form, surgery seal, and flow seal. No cautery at all. No cautery and no shaver in the sphenoid sinus. Dr. Khalid Hilli, how you deal with orbital injury? I faced about 10 or 15 orbital injury. Most of it was very mild. If there is severe injury and bleeding from the anterior ethmoidal artery, I do medial decompression to decompress the orbit. If there is severe bleeding and the orbit become very hard, I do lateral canthotomy and cantholysis and give mannitol and Diamox post-op without any backing. I have to deal with the bleeding intra-op. There is a lecture about complication. There's a separate lecture about the complication of FESS. Dr. Haitham Nouri, there is extensive polyposis. Yes, if there is extensive polyposis, we can't count the cell. I used to do, there is my own approach. I have to do anterior ethmoidectomy. If I don't have a navigation system, I do anterior-inferior ethmoidectomy to remove all the polyp from anterior ethmoid to sphenoid. Then open the sphenoid and clear the sphenoid and clear the skull base from the posterior to anterior. So I use in the extensive polyps, I use posterior approach. Posterior approach is very, very safe. I don't use anterior approach at all in the extensive polyposis. Posterior approach is very safe. To define the hard skull base posterior from the planum, from the sphenoid planum, and goes anteriorly to the side of the frontal recess, then open the frontal recess and remove the rest of the cell. So I did anterior-inferior ethmoidectomy, then I did posterior ethmoidectomy and anterior superior ethmoidectomy. There's a separate lecture for this, for anterior-inferior. This is the new approach, anterior ethmoidectomy, and then posterior, then anterior superior ethmoidectomy. You're welcome, Dr. Majid. Dr. Hitham, you mean in the extensive polyposis on, or just in the inflammation, not polyp? Yes, safe to follow the frontal peak. Especially in the draft 3, I used to use a new approach for draft 3. It's called outside in technique. No, dear. In extensive polyposis, I do the posterior approach only, and then there is the frontal versus from the posterior. And then, yes, maybe I follow frontal peak, but I do it posteriorly first. Posterior approach, then go anterior. I remove, certainly I remove the anterior head and remove the incapacitating from the agarnase. I remove always the agarnase and extensive polyposis. Then posterior, then return the frontal recess. It's very difficult, Dr. Haytham, it's very difficult to find the frontal recess anteriorly with extensive polyposis without damaging the anterior femoral artery. It's very risky. So the posterior approach in this, I emphasize the posterior approach is very safe in extensive polyposis. Okay, no further question. I will terminate now. Thank you for listening. Goodbye.